Welcome to The Explainer. Today, we're jumping into a true ocular emergency, something every single one of us in the ED needs to be able to spot and manage, like right now. We're talking about acute angle closure glaucoma. And believe me, this is one of those conditions where minutes absolutely count, and what you do can literally save someone's sight.
All right, so let's break this down. What exactly is acute angle closure glaucoma? Well, think of your eye like a sink. Normally, you've got this fluid, the aqueous humor, that's constantly being produced and then draining out. It's all balanced. But in AACG, something plugs the drain. The iris literally bunches up and blocks the drainage system. So the faucet's still on, but the drain is clogged. The pressure just skyrockets, and that's when things get really dangerous, really fast.
And I really want to hammer this point home. This is not just a sore red eye. The pressure inside the eye gets so high it's like a clamp on the optic nerve. It cuts off blood flow to the nerve and the retina. If you don't relieve that pressure, and I mean fast, permanent vision loss can start within just a few hours. There's no playing around here. It is absolutely a sight-threatening emergency.
Okay, so here's how we're going to tackle this. We'll walk through it just like a real case in the ED. We'll cover recognizing the patient, the exam you need to do, how to manage it on the spot, and then what happens next. Let's get into it.
Right, first things first, who is the classic patient? What should make your spidey senses tingle when someone walks into your ED?
You know, there's a classic triad of symptoms you really have to look out for. First, the pain. We're talking severe, often described as a deep, boring pain in the eye. Second, their vision gets blurry, and they might mention seeing halos or rainbows around lights. That's a huge clue. It's from the cornea swelling up. And third, you'll see a red, angry-looking eye. You see those three together? AAG should be screaming at the top of your differential.
So beyond the symptoms, who are we looking for? Well, there's a definite patient profile. It's about 4 times more common in women. We also see it a lot more in people of Asian descent, and that's because of the anatomy of their eye. Also, a big one is being long-sighted or hypermetropic, and you always want to ask about triggers. The classic story is someone who is in a dark room, like a movie theater. Why? Because in the dark, your pupil dilates, which can cause the iris to bunch up and bam, close off that drainage angle. Stress or even certain meds can do it too.
Okay, so the history is pointing you in the right direction. Now it's time to confirm your suspicions with the physical exam. This is where you'll find the really crucial signs.
The absolute #1 thing to look for is the pupil. This is the classic sign. That sky-high pressure is so intense, it's actually causing ischemia. It's cutting off the blood supply to the little muscle that constricts the pupil. So what happens? The muscle is stunned, paralyzed, it gets stuck in a mid-dilated position. So when you shine a light in that eye, you'll see it just sits there. It's either totally fixed or maybe just a little bit sluggish.
And we're talking a pupil that's stuck somewhere between 4 and 6 millimeters. It's a dead giveaway compared to a healthy, reactive pupil.
All right, next up, the pressure. You got to check the intraocular pressure, or IOP. A normal eye sits somewhere between 10 and 20, but in AACG, forget about it. You're going to see pressures way, way higher. We're talking over 30, and honestly, don't be surprised if you see numbers like 50, 60, or even 70. It's just off the charts.
And you know, even if you don't have a tonometer handy, there's a quick bedside trick. Have the patient close their eyes, and then you can gently palpate both globes. The affected eye will feel, well, rock hard. Seriously, it's like pressing on a marble compared to the other eye. It's a really useful sign that'll tell you something is very wrong.
So let's play this out. You have a patient, they've got a super painful red eye, you're thinking, this could be it. But then you shine your light, and the pupil reacts perfectly normally. What do you do now? What does that tell you?
This is a huge, huge point. If that pupil is reacting normally, you need to step back and think again. It's a major red flag against a diagnosis of ACG. It just doesn't fit the picture. So it's time to consider other things that can cause a painful red eye, like acute iritis or keratitis. That reactive pupil is your cue to broaden that differential.
Okay, you've made the call. It's acute angle closure glaucoma. Now the clock is officially ticking. Everything you do from this point forward is about saving this person's vision. Let's talk about ED management.
All right, what are your first 2 moves? They're super simple, but absolutely critical. 1. Get their pain and nausea under control right away. Use IV meds. These patients are often vomiting from the pain, and vomiting just spikes that eye pressure even higher. 2. Get on the phone with Ophthalmology. This isn't a let's see consult. This is an urgent call. They need to know about this patient now.
Now for the meds. The goal is to bring that pressure down. And a good way to remember the drugs is the mnemonic TAMP, because you're going to tamp down the pressure. So T is for timolol, and A is for acetazolamide. Those two work by turning down the faucet, reducing how much fluid the eye makes. M is for mannitol, an osmotic agent that literally pulls fluid out of the eye. And finally, P is for pilocarpine. This one constricts the pupil, and by doing that, it physically yanks the iris away from the drain, helping to open it up.
But a quick word of caution here, a really important one. Timolol, even though it's an eye drop, it's still a beta blocker, and it gets absorbed systemically, so you absolutely have to be careful. You do not want to give this to someone with asthma or bad COPD. Same goes for patients with a really slow heart rate or heart block. It's a critical safety check you have to make.
So you've done your part in the ED, you've stabilized the patient, the pressure is coming down, you've bought them precious time. But the story doesn't end there. Let's talk about what happens next, the definitive fix and long-term care.
The permanent fix for this is a procedure called a laser peripheral iridotomy, or LPI. Basically, once the pressure is under control and the eye is calmed down, the ophthalmologist uses a laser to zap a tiny little hole in the outer part of the iris. This creates a new path, a permanent shortcut for the fluid to flow through. It completely solves the plumbing problem and stops it from ever happening again in that eye. Pretty cool, right?
But here's the kicker, and this is so important. It's rarely just about the one eye. The anatomy that caused the problem in the first eye, well, it's almost always the same in the other eye. And look at these numbers. There's a 40 to 80% chance of the other eye having an attack within the next 5 to 10 years. That is a staggeringly high risk. You can't ignore that.
So what does that mean for us? It means our job includes making sure the patient understands this. The good eye needs to be treated too. Getting a prophylactic laser treatment in that other eye isn't just a suggestion, it's the standard of care. It prevents them from ever having to go through this whole ordeal again, and more importantly, it prevents potential blindness in their other eye.
Which brings us to the final critical thought I want to leave you with. When you treat a patient for this, you have to ask yourself, I've saved the vision in this eye, but what about the other one? Our job doesn't end when the pressure is down. It ends when we've made sure there's a plan in place to protect all of their vision. It's about saving not just one eye, but both.